So today I'd like to welcome Leeanne O'Hara, Dr Leeanne O'Hara, who's a Senior Research Fellow and also Scientific Officer for the NICOLA Study at the Centre for Public Health in Queen's University in Belfast. So the NICOLA Study is the Northern Ireland Cohort for the Longitudinal Study of Ageing, and it's a prospective cohort study which was set up in 2013 to explore how and why certain social, economic and biological factors are changing the lives of older people and understand what it's like to grow old in Northern Ireland. The NICOLA study has comparable data with the English Longitudinal Study of Ageing, ELSA, and also the Irish Longitudinal Study of Ageing, TILDA. So today, Leeanne is going to talk to us about an overview of the NICOLA study and discuss a collaborative paper that has been published on the prevalence, characteristics and associated mortality risk of frailty on Northern Ireland and the Republic of Ireland. So, Nicola, thank you.
Thank you.
I knew I was going to do that. I said to myself, don't call her Nicola. So, Leeanne, I'm sorry.
It's okay. I'm happy with Nicola. Hello, thank you for having me today, and thanks for the introduction. So I've been working on the NICOLA study now for about 4 or 5 years, predominantly on a sub-study, which I'll tell you about in a moment. And more recently, I've moved on to the parent study, which is going into wave 3. So I'm quite new to the role as scientific officer from February time this year. So as I say, I'm just going to give a brief overview of NICOLA itself, what stage we're at, and then I'll move on to looking at some of the collaborative work that we've done with TILDA in the area of frailty. So yes, just as a so NICOLA is the Northern Ireland Cohort for Longitudinal Study of Ageing. So it's the Northern Ireland's largest public health cohort study, longitudinal, and we stratified a random sample of approximately 15,000 private residential households, and these people were born on or before the 30th of September 1962, and in our first wave, people weren't eligible if they were institutionalised or lacked capacity. So what we plan is repeated interviews approximately every 2 to 3 years with a health assessment every 4 to 5 years. We use sample weighting, and we also have a unique focus. So although there's a lot of these ageing population studies, the one for Northern Ireland has a unique focus, particularly in terms of legacy of the Troubles, and we also have components on nutrition and eye health. Yeah, so just in terms of the stages of our data collection, so we have completed wave 1 that was administered between 2013 and 2016, and that consisted of our computer-assisted person interview, our CAPI interview, and we managed to interview 8,478 participants. We also accompanied that with a self-completion questionnaire, which sort of explored some of the more sensitive issues that weren't asked face-to-face, and we had 5,032 of those returned. We had a health assessment. 3,741 people participated in the health assessment. So that's an invitation that goes out, and people have to then volunteer to come into our research facility, our clinical research facility on site at the City Hospital in Belfast. And then we had a dietary questionnaire, and we just had just under 3,000 people completed that. So wave 2 then began in 2017 until 2019. This wave just included the CAPI and the self-complete questionnaire. And we also had a cohort refresh at this stage. This is just to refresh our younger age group from the 50 to 54-year-olds. We also administered the COVID-19 questionnaire because obviously COVID hit us just right at the end of wave 2. And we had just over 3,000 people that returned that during the pandemic. So we also have wave 3, which is in planning and due to commence soon, and it's going to replicate more of what wave 1 included. So that's the CAPI SCQ dietary questionnaire and the full health assessment. So the types of data that we collect, very similar across all the longitudinal studies of ageing, if you're familiar with TILDA and ELSA and the health and retirement study. As I say, the Northern Ireland Cohort has some bespoke elements, but as you can see there, we collect similar socio-demographic factors, lifestyle behaviours, psychological and social factors, general health questions, objective health measures, information on economic factors, and healthcare and health service utilisation. So there's a vast database there which contains data from right across the board, all of which is very similar, if not harmonised, with some of what the other studies collect. The health assessment itself, so we look at physical health, cardiovascular function, cognitive health. We take some biological samples. We look at physical function, respiratory function, mental health, dietary intake, and in wave one we also took a facial photo. So as I say, everything is done at our Northern Ireland Clinical Research Facility. We ourselves are housed at the Royal Victoria Hospital in the Centre of Public Health, and this takes place over at the City Hospital, so we obviously have the transfer of samples and things like that, but we use the facility across in the City Hospital. So just to draw on some of our more bespoke measures, I'll not go into this in any detail. If you're interested in eye retinal imaging, you can always feel free to get in touch. So our colleague Ruth Hogg leads this in NICOLA, and we have retinal imaging, colour fundus photographs, wide field colour images, optical coherence tomography, and multimodal imaging. So the multimodal imaging in particular enables prevalence data of new phenotypes and associated risk factor analysis. So that's quite unique to NICOLA. We also have the biochemical biomarkers. So analysing biological samples allows us to objectively evaluate biomarkers that help provide information about a person's health. So we take blood samples and urine samples, and this year we're planning to also do a fecal sample. As I say, they're transported and processed from Belfast City Hospital within 4 hours of collection. And the different biomarkers that are and derived phenotypes that are available in NICOLA are included in these tables. So again, we have a vast area, a range of what's there. So we have cholesterol, protein, with calcium, testosterone, vitamin D, so anything that would be of interest. So molecular biomarkers as well. So epigenetics provides a link between our inherited DNA and environmental influences from a person's diet, medication and lifestyle. So we have a vast molecular biomarker database, and that is led by my colleague Professor Amy Jane McKnight. So if you have any interest in that, I can obviously point you in her direction as well. So just in terms of what we've done with sub-studies with NICOLA, the Harmonised Cognitive Assessment Protocol, this was a study that I led on when I first joined the Centre for Public Health. So this is funded through the National Institute of Ageing in the US. So it basically aims to investigate dementia risk using a harmonised cognitive assessment protocol as part of this larger NIA-funded study. So the Health and Retirement Study in the US, they basically developed this harmonised cognitive assessment protocol. And it has been replicated in TILDA, ELSA and various other projects across the world. So we managed to administer the protocol to 1,037 NICOLA participants all over the age of 65. And this work will generate an extensive global dementia bioresource and produce internationally comparable data. So the harmonised aspect of this was quite thorough. And in fact, we worked very much in partnership with TILDA. Our funding was with TILDA, but obviously we're well harmonised with the likes of ELSA and others. So you can see there the reach of the HCAP sub-studies. So those in yellow, this is our HRS and standalone HCAP studies. And you can see HCAP only really exists down, so most have the parent study and the HCAP study. Another sub-study that we had was the space study, so supportive environments for physical and social activity, healthy ageing and cognitive health. So looking at the environment, so where we live may influence brain health and vulnerability to cognitive impairment. So the key research questions with our space study are there specific factors which make urban environments a problem for brain health? And what are the best policies and interventions for promoting healthy ageing and brain health for our poorest communities? So our space study actually was linked on to the HCAP study, and that involved our nurses when they were going out into the field to administer the cognitive battery of tests. They would have asked participants if they'd be willing to wear an accelerometer, which they were able to wear around their waist for a week. And that basically, so an octograph and accelerometer. So that was allowing us to pick up their monitoring the location and travel via the GPS devices. So most people actually, I think we managed to get a final sample of 500. So roughly half of our participants agreed to take part in space, which was quite a good response rate based on other studies of its type. Okay, so just moving on to where we are currently. NICOLA, we have 3 objectives. So we're wanting to maintain core modules from the previous waves, along with some of our new measures. We want to conduct quality assurance of the data from the 3rd wave, but we also want to include linkage with data from the 1st and 2nd wave, as well as data linkage to administrative data that's available in Northern Ireland. We want to generate new insights to gain a better understanding of the pathways underlying and the trajectories of healthy ageing. We want to expand the characterisation of the exome by compiling additional environmental data from open sources and linking them with Wave 3 data. So that's just, as I say there, to the biobank. We want to continue to archive data and metadata to further enhance the infrastructure for ageing research in Northern Ireland. And we want to provide comprehensive national and internationally comparable data to allow for a cross-national analysis. We're also keen to, again, increase our PPI and stakeholder participation. So our study timeline, we began in April 2024, so we've really just been through ethics and study prep and study setup. We are planning to go into the field in November. We're going to start with the CAPI and our health assessment then, subsequently from that. We have employed Ipsos, which is an external survey company, to administer the CAPI for us, but our own nurses will be doing the health assessment in our, as I say, in the clinical research facility over at the hospital. So Wave 3 will include the cohort of NICOLA participants who participated in Wave 1 and 2 and who consented to follow up. So our proposed sample size is approximately 6,000. And we hope that at least half of those will opt to take part in our health assessment. So this is really just a data collection overview. As I say, the Ipsos staff will be administering the computer-assisted interview. Self-completion questionnaire will be postal return. And the health assessment, the only thing that we're including which was included in Wave 2, but being followed up again this year, is the proxy interview or the end of life, which is where participants are unable to complete the interview, but they've consented to follow up and they've since passed away, so that'll be with next of kin. Okay, so just in terms of the CAPI measures, you can see there that Wave 3 will encompass everything that was in Wave 1 and Wave 2. And we've also, through discussions with other longitudinal population studies and through some of our own research, have developed some new measures to be included around food insecurity, fuel poverty, financial well-being, our geospatial data, climate change, digital or AI questions, and people's perceived age. So these are our new measures that are going into the CAPI. Okay, so the health assessment, again, completing everything as per Wave 1. We've added an additional hearing test. Before it was self-report on hearing, so we're actually doing a physical hearing test. And we've also, as I say, added the fecal sample. We've also moved the MMSE into the main CAPI, and that's really just to capture a greater number of participants. As I say, it's really normally only roughly 50% that will complete the health assessment, so just to capture more response in MMSE. Mini mental examination, so that's for our cognition. So before it was in the health assessment, but we were only getting that on the smaller proportion. Okay, so we have some data that's commonly requested. As you can see here, it ranges from attitudes and behaviour, smoking, alcohol, through to education. We've had quite an interest in our genomics, our cognitive measures, in our troubles data. However, we've got quite a lot of underused data as well, which As you know, in research, we don't want that to happen. So really what we're trying to do now is build on some of this underused data. And we're encouraging people to apply, obviously, to use the data through NICOLA. And data access, there's information for researchers on our website, and there's also what we have is our data access committee, and I would manage the applications that come in for access to data, and then we meet as a team to assess that. So all the information of getting access to data is available here. Our data dictionaries are available as well, which shows you, right down to the variables that are included and what measures that we have in NICOLA. We have 1, 2, 3, and our health assessments, SCQ, and our food frequency questionnaire as well. So if anyone's interested, you can either contact me or have a look on our website. Okay, so in terms of impact, yeah, we have over 70 published papers from across the board. So these are just a few examples. We've got a number of PhD students working on the study. And as I say, we do encourage collaboration, whether that's with other LPS, but other external researchers as well. So anyone can apply to use our data within the context of their own work, admit a proposal to ourselves in the Data Access Committee. And as I say, around data linkage, so we're obtaining consent from our participants this year to start the process of data linkage. So our business services organisation in the North that will allow us to link in with hospital admissions data, for example, and other data that we obviously good for in terms of respondent burden and not having, obviously if the data's there, linking it rather than collecting it ourselves. And we're also intending to link in with the Northern Ireland Cancer Registry as well, so that's on the agenda. Data deposits and archiving. So this links in with the collaboration with our other LPS as well. So as part of our remit, we have agreed to deposit our data across a number of platforms, as have quite a few of the other longitudinal studies. So, for example, Gateway to Global Ageing, some of our data is already available across many of these. We're currently preparing our first set of the cognitive assessment protocol data, which will also be deposited. And we're also a member of the CLOSER consortium, so the home of longitudinal research across the UK. So I know some of your colleagues across the university here are also involved in that. So in terms of frailty, frailty is an area that I know that you had mentioned it as a specific area of interest here. I personally haven't worked on the frailty work within public health, but I thought it would be a good opportunity to showcase it here today of what's actually been happening. So just as a basic introduction to anyone who doesn't work directly in the area, so frailty is a geriatric syndrome which is common with advanced ageing and is characterised by increased vulnerability to stressors due to age-related multi-system loss of psychological reserves. So obviously this vulnerability increases the risk of adverse events, including hospitalisation, institutionalisation and increased risk of mortality. So such negative outcomes coupled with the increasing prevalence among rapidly ageing populations makes frailty a key public health challenge, and a greater understanding of the region level frailty prevalence will inform policymakers and planners to better configure services and develop preventative approaches. So in terms of this collaborative example, so one example of the NICOLA and TILDA studies, so frailty on the island of Ireland. So Ms. Jasmine McKelvey had collaborated with our colleagues in the Centre of Public Health on this piece of work. So I'm just going to really give you an overview of what was done and the evidence from that. So it aimed to compare the prevalence, characteristics and associated mortality risks of frailty in Northern Ireland and the Republic of Ireland. So cross-border and all-Ireland cooperation has increased significantly in the recent years, in part due to the withdrawal of the UK from the EU in January 2020 and the impact of COVID-19 pandemic. There has also been, from the Belfast Agreement, Peace Plus money that came into Northern Ireland, and a lot of cross-border work through the North-South implementation bodies. The increasing ageing population presents a shared challenge across the island of Ireland, as it's accelerating more rapidly than other EU countries. So the NICOLA and TILDA studies provide a perfect opportunity to explore this, given they are representative of the populations aged 50 and above, to be pulled together in terms of all Ireland statistics. So again, this is one of the benefits of these longitudinal studies when they're harmonised. So we continue at each stage to try and harmonise with, as far as we can across the globe, but primarily with TILDA and ELSA, to allow us to be able to pull this data together. And as far as I'm aware, we can you can also access the TILDA data and the ELSA data for your own work. So in terms of methods, so it's a secondary analysis of the first wave of the two cohorts. The NICOLA study, there was 8,183 participants, and for the TILDA, it was 8,159. So Frailty was operationalised for this paper using an accumulation of defects Frailty index, derived from participant-reported information on 30 impairments and illnesses from the CAPI. It was used for both studies. So the 30 reported health deficits included, for example, cardiovascular conditions, chronic conditions, physical limitations, memory, daytime sleepiness, urinary continence, pain, and polypharmacy, which was consistent across both studies. So you'll see in the literature the use of the Frailty index in encompassing these different conditions to give us a score. So continuous score between 0 and 1 was calculated for all respondents, and Frailty status robust, less than 0.1, pre-frail 0.1 to 0.24, and then frail above 25. Okay, so after waiting for representativeness, what was interesting in this paper was that the prevalence of frailty was almost twice that of what was in the Republic of Ireland, so 29% versus 15%. So for both studies, it was consistent. The mean score did increase with age, with females having consistently higher scores than males, and this sex gap was wider for NICOLA over TILDA. In terms of other demographic characteristics, so we've mentioned increasing age and being female there. They were also non-married or having a lower educational attainment, and living in intermediate or urban areas, so they were all significantly increased the likelihood of frailty. The proportion of respondents who died during the follow-up was comparable between the two studies, so we obviously have links to mortality data. So of those identified as frail, 19.7% died during this period in NICOLA and 27.9% in TILDA. The proportion of pre-frail respondents who died was approximately half those as who were identified as frail. So we also have the timed up and go test in our health assessment. So this was also included as part of the paper, which is an objective measure or indicator of frailty in both NICOLA and TILDA. So the findings were consistent to that of the 30 item. When NICOLA and TILDA health assessment samples were pulled, NICOLA respondents were still twice as likely to be identified as frail by this objective measure of frailty. Yeah. So just to conclude, so using these two large representative population-based cohorts, we've demonstrated that frailty was common, generally associated with the same demographic and socioeconomic factors, and was a strong independent predictor of mortality risk in Northern Ireland and the Republic of Ireland. However, Northern Ireland respondents were twice as frail compared to their counterparts. We've also actually recently found out as well that in terms of depression, it was actually a recent seminar we were at over in the US, Northern Ireland has a much higher rate of depression as well than in the Republic of Ireland. Now again, could be based on some of the troubles, the conflict. So again, we're looking into that actually with ELSA and TILDA at the minute. So anyway, back to frailty. These findings concur with previous attempts to examine frailty in the island of Ireland, and evidence that older adults have worse rated health and lower quality in life and higher disability in Northern Ireland. and coupled with higher rates of depression as well. So the relationship between frailty and mortality found in both cohorts corroborates previous research, which was consistently linked with FI and the increased mortality risk. So a definitive explanation of why those in Northern Ireland have more frailty compared with the public of Ireland can't be determined by this cross-sectional study. So that's something that needs to be looked into in other work. So I just really wanted to finish up by pointing out some other work for anyone who's particularly interested in frailty. So Ruth Fergie is a colleague of ours. She's a clinician and is a doctor. And she's working in the area of kidney transplantation and the latest advances in frailty. So in terms of her area of work, frailty's emergence as an important risk factor for those waiting for kidney transplantation. But most of the published research to date comes from a single transplant centre in the USA. So frailty in this aspect is measured using the physical frailty phenotype. And although kidney transplantation is substantial psychological stress to patients reserved, by restoring kidney function, kidney transplantation has also been shown to actually improve a patient's frailty status. So this is the most studied tool in patients waiting for transplantation, but it's not been able to distinguish those whose frailty is improved by kidney transplantation. So there's significant gaps. What they find in the narrative review is that there's significant gaps in how frailty is actually measured to inform decision making, in this case around kidney transplantation. Further research is needed to address these important gaps in the literature. So Ruth has moved on to start her PhD in this area, and she has a keen interest in what is subjective in terms of and objective measures of frailty, and looking at how these are actually measured across the board. Yeah, so her PhD is investigating whether frailty predicts outcomes after renal transplant and whether it is modified by renal transplant. At the moment, she's worked with over 160 participants and is on track to meet 200 by Christmas. So that's really a watch this space stage with that. So just to acknowledge the funding that we've had throughout the course of NICOLA.
Okay, I think we can thank Leanne very much for her presentation today, and let's get started on the research. Thank you.